On cochlear implants, basically some points were covered which are not related to hearing preservation mainly, but other things like under local versus general, and also some issues with the electrode and so on.
What we'll do this time, Bruce, is it is a little bit difficult for us, but I will interrupt you when we're about half an hour in to try and bring the audience in to make it all inclusive. Because of course, what we're trying to do is make it as inclusive as possible. So pretty much for the first half hour, you've got free reign. And after that, you may see me coming in saying, oh, Bruce, by the way, we've got a question from India or from Malaysia or from Australia. And we'll try and involve the audience, maybe even get them into the picture. But I don't know whether we'll be able to do that.
Do we still have 2,000 people on?
Well, we've got that many registrants. We've got a few hundred connected at the moment, and it's changing all the time. So I think 2,000 registrants means that during the day, 1,500 may come on, but it may be at different times of the day. But if you reckon there's between 380 and 500 watching you at any one time, that would be realistic at the moment.
Okay.
So I can see in the top corner that everybody's gradually gathering. Joachim's there, up at the top.
Good morning.
See him.
Joachim.
Morning, Joachim. Morning. Hi. We're just
Does he have his bow tie on? I can't see him.
Yeah, he always bound to. Yes. We're just waiting for.
And I assure you.
Yeah. We're waiting for.
And it's in the right color.
Yeah.
Oh, it's in the red color this time. Thank you, Joachim.
Yeah.
I was
you have a red car.
Yeah, he had a black one on yesterday. I was out of character.
Yeah. But you have a red car, so I changed the color.
Okay, good.
Let's give Wilco a ring and see what's happened to him.
Hey, John, can you only see me?
Are you there? Wilco, are you there?
Hello. Yes, I'm here.
Good. Phew.
Bruce, can I suggest that we start your video and you want to do the wording yourself?
I'll do the talking if you don't mind, and then I'll tell you to turn it up when we're starting the monitoring.
Just tell me. All right. There we go.
Right, so this morning, put it on mute and we'll go. Okay. Put on. Oh, Tom, go ahead and put that. Cochlear implant. This is a device that is designed for hearing preservation. And we will be monitoring ECOG while we place the device. So the patient this morning is a gentleman who has a family history of hearing loss. He also has a little bit of noise exposure as a truck driver. He's been using hearing aids for the past 10 to 15 years, and he came in with much difficulty understanding words, and he was a candidate for a cochlear implant. As you can see, his audiogram here, we're going to do the right ear. In the low frequencies at 125, he's at about 40. At 250, he's at 45. And at 500, he's at about 55. So he's got about a 47, 48 dB pure tone average in the low frequencies. So we'll go ahead and do the procedure, and we will monitor and we will show you how we do that. All right, so basically we're just doing a very small mastoidectomy, but you have to make certain that you are thinning the posterior canal wall so you can look down the posterior canal wall. I also undercut the tegmen. So you'll see later on that I'm going to make a couple of drill holes here to hold the suture to hold things in place. But you need to identify the incus, and you don't have to expose the incus. You can see it in the water that magnifies, and you can see it coming up here. Now I'm going to use a 3-diamond to start opening up the facial recess to give me some exposure. Then I move to a 2-diamond, making certain that I preserve the chorda tympani. That's not always possible, however, as you know, and you have to tell the patient that there could be some alteration of taste. After identifying you see the incus, and now we're going to open this with a 1.5 diamond to get a little bit more exposure of the round window. Wilco, can you put this on a larger zoom for me?
It is for you. It is on a larger zoom.
Okay, fine. I'm not seeing it larger, but that's okay. Anyway, you'll see that we carefully identify the round window, and make certain that I don't actually expose the whole round window. I make certain I see the anterior inferior aspect of the round window, and I use a 1 millimeter diamond burr to do this. And you don't have to use much irrigation if you do this slowly. I don't turn the drill up at a very fast speed, maybe at half speed as I'm opening that round window niche to get a good view of the round window. And you'll see here now a Farrier rasp, which is just a disc that I use to clear the round window. And now this is the drill holes in the tegmen mastoideum. I just use a small diamond burr here, and then I use a 4 nylon suture. I undercut this to make sure that the electrode now will lie, come down through this area, and then go straight down into the round window. So here's a suture going in. Just a nylon is all I use. I've never had this cut into the electrode. I don't really tie it that tight, but it's just enough to hold the electrode in place. And you know, these straight electrodes have a tendency to work their way out of the cochlea if you're not careful. So this helps to stabilize that electrode. In my hands, this is what I've always done. I learned this from Graham Clark, that some of the original electrodes that we did back in the early 80s did work their way out. And so stabilizing it is important. So we'll now put the, I guess we'll clear the round window a little bit more. There's the electrode going in. This is a Cochlear Corporation 624. It's a new electrode that's 20 millimeters in length. It's got a little curve on the tip, and it's based off the 622 or the 522 or 422 electrode, but they took the stiffener out of the basal 10 millimeters, which I think was damaging to the electrode or damaging to the cochlea. So it's a softer electrode. It works a lot like the Med-El 24, Flex 24, maybe slightly stiffer than that, but it's a nice electrode. And you'll see we'll go through the suture here, and now we're tightening the suture to hold it in place. This is the ECOG monitoring device that is built into the electrode, and we have a microphone in the ear canal, and we're stimulating with clicks, and we're generating clicks, and we will monitor the ECOG as we are inserting the electrode. So now I'm clearing a little bit more, and I'm going, and I have, I'll put in some Decadron that I'm sucking out here. I put a little Decadron in while I was doing all this manipulating, putting the electrode package in place. Now, I think you're able to see there's the needle electrode, and I will go right anterior, inferior, and just make a little incision in the round window. I put that on that electrode. It's a 27 gauge needle. I put it on a hemostat to do that. Now I'm using a fish footplate hook to open that round window a little bit more, just right on the annulus. I don't really open it widely, just enough that the electrode can slide in and not hang up on the round window. If you don't make it large enough, it will hang up. Now, if you're going to suck in the ear, just like on a stapes, take your finger off that the extra portion there, that so you don't venturi it. And now we'll put the electrode, take the electrode back. You can see the electrode, it has a little wing on it, just like the 622. You can see it's a little bit curved. I'll take the sheath off now. The wing goes inferior. Okay, Wilco, you can turn up the volume now. Wilco, do you hear that? Okay, now I'm just putting the electrode in the window, and now I will adjust it so I can let go of the electrode. And I'll have my assistant now tighten, and I have the electrode in the window, and I will just, I can let go of it, and it's stable. And you see how vertically it's going down the posterior canal wall. I'm just, that's the monitoring electrode, or monitoring portion, so that the receiver, so that it hooks into the monitoring system. And now my assistant electrophysiologist will give me the microvolts as I am from the ECOG, as I am trying to insert, and you can listen to this.
Just stop. Hold on 1 second.
And I take time. Sometimes I take 10 minutes to put an electrode in, but because it's stable, you're not wiggling it in the inner ear.
Okay, we're good. You're getting something here.
You got something?
Yep.
Okay. What is it?
It's at 4 right now.
Okay. So that's 4 microvolts.
You're up.
I advance
7.
it slowly. Up to 7.
Still steady. Still at 6. 8. 9. Still holding steady. Still good.
And I'll adjust the electrode so that it doesn't put any pressure on the cochlea. But I just very gently try to put in a 1 or a ½ millimeter at a time.
11. 12. Still steady.
So there's about 6, 7 electrodes out yet. This is a 20 millimeter electrode. And that white line is at 20 millimeters.
Still holding steady. You're at 20 now.
Now it's hanging up a little bit,
stable.
and I'll adjust the wire.
35, 40, 28 now.
So I'll have my assistant loosen,
you're at 30 now.
and I'll pull it back a little bit so that it's more vertical going down into position.
Still stable. 35, 40, 45, 50, 45, 65. You're at 65 now.
I'll adjust again.
Still stable at 65. Still good. 70. Still good. 45. You dropped down to 45.
So I didn't move it now, and I will, whoops.
This morning we're going to do the first
Wilco, you lost it. There we, okay. Now, this is the, go ahead, Wilco.
Now.
Okay, let's go, keep going.
Still 50.
Okay, it's at 50 microvolts. Now you're going to see the same thing with my assistant, my electrophysiologist, and here you go. He's over here on the right side. This is the just a monitor, and me doing the same kind of thing. Showing how slowly we're putting it in. But I think that's really key, that you work with your electrophysiologist, because you can move the electrode in and out a little bit sometimes, and you can, as the ECOG amplitude decreases, you can pull it out and readjust it. And that's worked very well for me in a number of cases. I've done that with the transphonics electrode and with the cochlear incorporation electrode in their software. Works very well. After we're done with this, after I tie it in place, you see me tie the electrode in place with the suture, and then here's the suture. I'll put a little Decadron in the middle ear, and then I will tie this suture, and then we'll do an audiogram, an ECOG audiogram. And when we finish this at 500, we can do that at 500 hertz and at 250 hertz. This is just tying that suture, and it keeps everything in place. And once that is tied, then I can manipulate the electrode into the mastoid. Some people have told me after they've saved the ECOG and they've manipulated the electrode, you lose it. And so this is very stable now, and I feel really good about this point. And now I'll take a little bit of fascia. There's the ground electrode going in for the cochlear device, and then I'll take a little piece of fascia from the muscle, and I will put it down in the oval window, and making certain that I don't put too much in to inhibit the conduction on the stapes. So just a small little piece of fascia that I've taken, with a straight needle, I'll put that right down around the oval window. When we were done with this, my audiogram demonstrated at 500 hertz at 55, which was really good because we started at 55. He came back at a week and a half post-op, and we lost about 7 dB at 500, which is pretty consistent, between 7 and 10 to 12 dB drop after you put the electrode in. All right, then we just close the wound, and I use some monocryl on the soft tissue, and then we glue it. This is an outpatient procedure. We use Dermabond to glue the skin, and we send them home with a mastoid dressing in place for a couple of days. They can cut it off and then they can shower, and there's not much problem. So that's the way we've been doing this for about the last 5-6 years as an outpatient, and I think the patients like that. That's about all I have. John and Wilco?
Just a quick one, Bruce. You learn little tips from watching a master at work. I thought it was very interesting the way you reversed the needle to go through the 2 little pilot holes that you'd drilled. Is that something? Is that something that just came to you, or did somebody
because
teach
it hangs up. If you try to stick it from underneath, sometimes you can't find the hole.
Brilliant move. There's a question coming in from the audience from the Zoom room, and we'll let the chair go on after that, from Mariana de Carval. What suture do you use to stabilize the electrode? Do you have a preference?
It's a 4-0 nylon.
Right. And the second question is what's the role of Decadron? And is there any role of giving systemic steroid, do you think?
So we give 10 milligrams of Decadron. The anesthesiologist always gives that. Right. We post-operatively, we give 7 days of 60 milligrams of prednisone. And then right before we stimulate the electrode, the day before, we have the patient start on prednisone again for another week. And we found that we needed to, that early on with some of our hearing preservation procedures, we saw some drops in hearing. And so we started adding the prednisone post-operatively because we thought maybe we were overstimulating the cochlea. And so that's why we do that. So we give.
Perhaps we should hand over to Joachim Muller, because he's the chair of this session, not me. So Joachim, maybe 15 minutes of chairing the panel, and then we'll come back to the Zoom audience after that.
Yeah, thank you very much. Thank you, Bruce, for showing this nice video. But of course, watching other experienced surgeons always raises question. And I've put down 3, which I will pass around in the audience and ask for individual comments. You mentioned the drill when open the cochlea. From acoustic neuronoma surgery, we know that about 6,000 to 8,000 rounds per minute would be a good speed to not damage the cochlea due to drilling. I would like to hear the comments of the other panelists to that. Also, I'm afraid to use nylon because from the early days we know that can damage electrodes and cause wound healing disturbances and also cholesteatoma. Do you share this? And maybe why don't use a resorbable suture? But the major point for me was to see that you have largely opened the facial recess, which we should state and keep in mind as one of the success key points in inserting the electrode, thus nicely, gently, and atraumatic as you have shown. But in our hands, we have also a little difference. We use it underwater technique, and I want to draw your attention to Yamauchi from Japan, who has continuous prednisolone irrigations while inserting the electrode. And with these small comments, I would like to ask the other panelists to share their experience, give tips of their personal experience, which should be mentioned during surgery, and then we continue with the general discussion. Maybe I see Michael Tong.
Hi.
Hi. And maybe we start with you, and then we continue.
Very good. Very good. Can you hear me?
Yes.
Can you hear well? Okay.
Yes.
About the drill, nobody told me before, but we started with the Skeeter, which is not a very fast drill, but it was set fixed drill speed. More recently, because we were using some endoscopy technique, then we find out that slow drilling is a lot better. But so I echo with you. that now I'm using 6,000 to 8,000 RPM, and we found a much clearer view. So resorbable suture, I do use more resorbable sutures than say I use Micro inside. I don't really fix the electrode myself, but I do resorbable suture. Underwater technique, I'm actually using topical dexamethasone as an infusion and put it wet to the field while I'm inserting. So I'm diluting my 4 milligram per mil, so to about a little bit less concentrate because we're opening up the round window. So I would dilute it 2 to 3 times. I put it underwater, but I'm not sure whether it really helps.
Yeah, well, thank you. I think diluting is also a question that can be discussed later with the audience.
Yes.
Can we have one more comment from the panel?
Well, I use to the skitter to open the round width with 6,000 RPM, and I do as Bruce teach me at the last course of Thomas. I put some Decadron before the insertion of the electrode, but I don't do underwater insertion. I fix the electrodes with cotton suture, not nylon, because I think nylon it's a little bit sharp. But I used to fix the electrode too, even because doing bonus will the fixation of the internal device, I think it's more rigid with a knot of suture. This is my brief commentary. Thank you. And thank you, Joachim Muller, to allow me to participate of this debate.
Well, it's our pleasure. Hi.
Can you listen to me? Antonio Della Volpe.
Antonio, I'm sorry, but in my screen you're behind a picture. So now we give the word to Italy. Antonio, please.
Okay. My experience, thank you. My experience is only in children because my hospital is a children's hospital, so the situation is a little bit different. First of all, I can't usually perform a large tympanotomy because the anatomy of the young child is very different. Usually, I prefer cochleostomy because anterior-inferior cochleostomy because sometimes it's very difficult to perform surgery by round window because the space is very narrow. And I fix the implant using fascia bone dust in the cavity, in the mastoid cavity. I don't use any fixation with cotton.
Well, Antonio, you mentioned a side of the cochleostomy, and this gives attention to the fact that in children we have very often different proportions and different relations of the cochlea to the facial recess. Maybe this is also something others would like to comment on that, but this may make a nice round window insertion, as we have seen by Bruce. In children, sometimes a little bit difficult. What do you think?
Yes, I agree, absolutely I agree. In children, it's a different proportion. So in most of cases, I prefer cochleostomy, a very anterior-inferior cochleostomy. Sometimes I think it's very important to perform a surgery and to know the real length of the cochlea. Sometimes the real length of the cochlea is important to choose the perfect array for that patient. So there are some different systems. I think that we will discuss after about the system like Autoplan that I think to be useful in most occasions. What do you think?
Thank you. Well, I agree.
Joachim, can I comment?
Yes. Sure.
So So I'll tell you that when we started hearing preservation, we used Cochlea Ostomy all the time. And
Right.
I have patients that have preserved hearing for over 20 years doing a Cochlea Ostomy. So I'm not certain that it makes much difference. It's just the surgeon's strategy and how comfortable they are in doing the cochleostomy, because it has to be done very, very carefully, and soft surgery, like you all have done for many, many years, and make certain that we don't damage anything. But but a cochleostomy or a round window is equally sufficient.
I agree.
Well,
I agree with you. I think that the most important thing, just Bruce told before, is to use a very soft electrode. A lateral wall electrode, I think, is better in case of hearing preservation.
Right. I agree.
Well, I agree with the comments on the electrode, but Bruce, to make it more lively, I disagree with your comment that cochleostomy and round window approach are equally good. I have also patients from my teacher Helms where we had done cochleostomy and we have hearing preservation over 20 years, even at the term hearing preservation surgery was not invented. But if we look at the literature and we look at different groups and research on that, I have the impression that round window access is a little bit more reliable in hearing preservation than drilling in a cochleostomy. And I agree that's with you on the point that it's a strategy of the surgeon, but I think the discussion on hearing and structure preservation surgery leads more and more surgeons to what in the early days was called soft surgery. What do you think about that? Is Thomas Lenarz with us? I didn't see him on the pictures.
I think that.
Yeah.
I think that now soft surgery is mandatory, especially in children. Before, the indication for cochlear implantation was only profound hearing loss. Now the indication is a large indication with moderate severe hearing loss. So I think always we have to use that.
Michael, how is the situation
from the audience here? Can I put a question from the audience?
Sure,
Joachim?
anytime.
It's from Kanu Saha. How do the panel decide round window insertion or promontory cochleostomy preoperatively when they're considering hearing preservation?
Oh, who wants to start with a comment first?
Let me try.
Go ahead.
Okay. Michael,
okay,
yes,
so
please.
Okay. Preoperatively, actually, on a high-resolution CT scan, you can see the round window niche with the bone overhanging and the membrane under most circumstances. So that means that the patient is likely to have a normal anatomy. And out of this situation, we always plan for a round window insertion. So the other thing is about the electrode, obviously. If you have a very big electrode, a small round window, you might need to enlarge the round window. So that was in the older days. Now we are trying to use a small electrode, even with a small round window in the children. We should be able to do mostly. So some surgeons will have high percentage, some will have lower. I almost get to 100% round window. I might need a little bit of enlargement on anterior inferiorly for a few cases occasionally. I think it's important just to recognize whether there are anomalies before the surgery on this scan.
So I agree with you, Michael. Most of the time, I'm with the electrodes, the lateral wall electrodes that we're using. It's very easy to go through the round window, and the round window that I demonstrated was very easy. But you do have the occasional patient where the cochlea is tipped a little bit and it's more superior, like in children. And in that case, I would probably do a cochleostomy. And when I do a cochleostomy, I start with a 1 millimeter burr and I blue line and get a little spot. And then I'll take a 0.5 millimeter burr and try to open that a little bit more to thin it. And then finally use a foot plate hook or something to open and try to keep the endosteum intact. It's tough to do, but you can do it. If you do a drill out stapes, you have to use the same strategies as a drill out stapes.
Can I say something about anterior place round window?
Yes, please.
How I'm dealing
Michael?
with now. So actually, I moved the posterior wall, the very lateral part, anterior for these cases. So I will use a large burr, either a diamond or cutting as you're comfortable. I actually thin the most lateral part of the posterior wall. I thin it down so that I can actually move the wall anteriorly to get exposure. So I occasionally will move the chorda tympani as well. So I will move the nerve to get the exposure. So, and I don't find it difficult now because in the beginning, I might spend, say, 10 minutes in doing so. Now, maybe 2-3 minutes, I will be able to move the lateral wall. So, so that's why I found out myself that I can actually do round window for majority of patients, even their anterior place. So this is my little tip for that. Yeah.
I think that especially in children, it's very important imaging. And so before the surgery, I studied imaging of the patient to evaluate it's possible to perform cochleostomy or round window insertion. Cochleostomy should be drilled inferior and slightly anterior to the round window annulus to achieve scala tympani insertion and to avoid damage to the osteospiral lamina. In this case, I think that the results, just as Bruce told before, could be the same that by cochleostomy.
Well, Antonio, you mentioned Otoplan in the
Yes.
diagnosis and in the planning. As we have seen and discussed that on CT scan, you might see an overhanging or the round window, but with Otoplan, you nicely can turn the cochlea in 3 planes. Do you think this gives advantages? And can you comment a little bit on that? Because you were the only one who mentioned this new tool for cochlear implant surgery and individualizing the surgery. So please share your experience and tell us a little bit more.
I have experience. At the beginning, I had experience with the Otoplan only in malformation to evaluate the length of the cochlea and to choose the kind of implant of the array to use in that case. But I think could be useful also in other situations. The more advantage is to have the real dimension of the cochlea, to have the position of the facial nerve, but the other important thing is to avoid the mismatching of the frequency, because if you have a right length of the cochlea, you can evaluate this situation. It's also possible to do this evaluation after implantation, because in this case, you have results. You can do a fitting, a personal fitting for that patient, individual fitting.
Yeah, well, we did also a re-evaluation of all the cochlear implant cases with the Otoplan, and what we found extremely helpful is when the young assistants play around with the Otoplan, they get a 3-dimensional picture in their brain how the cochlea looks like, how the relations are. But we need to have a comment from Oswaldo on this point of cochleostomy or round window access. What is your feeling and your experience with that?
Well, Joachim, our experience is that we tried to put the electrode via round window, and we succeeded this in more than 19%. I agree that in some circumstances in children, the round wound is not easy to reach or to expose. And in some cases, we can do the Cochlea Ostomy. We try to do the way that Bruce described, but I think it's a little bit more traumatic than the round wind insertion, but at least in my hands. But it's feasible to do a cochleostomy without any exposure, preserving the endosseum of the cochlear ramps. So, but preferentially we do round wind insertion. One point that you mentioned that I think it's very important to discuss it. I would like to listen the opinion of the panelists, that many servers, they are saying that in children we should perform only the magnetic resonance as a study, because we can see the cochlear permeability, the cochlear nerve structure, the state of the cochlear nerve, etc. But to see the anatomy of the posterior, the tympanotomy, and to see the position of the facial nerve and the cochlear window, the round window niche, I think CT is much more interesting in doing this, describing this anatomy. So, do you have any objection to do CT on early child?
No, we usually perform CT scan and MRI before the surgery.
Yeah. Michael, how is it in China?
Both, we do both, CT and MRI.
Bruce?
Yes.
So there's been a negative feeling about radiation in children in the United States. And so we used to do CTs on everyone, but now all we're doing is MRI, looking at the T2 and making certain that we have the cochlear nerve and can see the cochlea. Again, you can't tell where the facial nerve is, but you know, for the most part, thank God that it's in normal position.
Michael, I stopped you in adding a comment. Would you please continue?
Okay. So I'm not sure about radiation concern. We don't have much radiation concern for the scan, but I'm a little bit old-fashioned because I can see the CT a little better on the cochlear anatomy and also the round window and also the relationship of the foot plate. The MR just lost some of the resolution sometimes for myself. So I'm accustomed to seeing both and combine the image in my own brain. I know the younger surgeons will fuse the image and do also some fusion scans as well, but I don't. I just fuse them in my brain. Yeah.
Antonio, you do both, or
Joachim?
Yes.
Can I just bring in a few questions from the audience?
Yeah, sure, anytime.
Yeah. Okay. So we have one question from Reda Al-Rumai. What is the long-term expectation of hearing preservation? What's the hearing like several years after the implant if it's preserved at the time of surgery? And then there's a question for Michael. He was talking about moving the posterior wall of the external auditory canal. In those situations, is the tympanomeatal flap, is there a tympanomeatal flap, or is that always kept intact? And then finally, we have one question asking about if you are trying to do hearing preservation surgery and you do not have an ECOG, what would the optimal duct length, without calculating duct length, what's the optimal depth of insertion in millimeters to give the best chance of a hearing preservation?
Okay. We keep the last question with the duct and insertion lengths for the end, because this will keep us busy for hours to discuss this. And I would like to ask Michael first to give the comment on the posterior canal wall, and then maybe Bruce can discuss something on the long-term outcome, because he's experienced also with his results on a long-term run. Michael first, please.
Yes. So when you elevate the skin, So I don't particularly detach the flap away, but sometimes the flap will come off a little bit on the lateral side. So I don't deliberately do anything to the tympanomeatal flap. So if it's come off a little bit, I just let it go off a little bit. And if it is sticking together, I just let it stick together. So I thin down only on the posterior side of the posterior wall. So I don't do anything on the anterior side at all to touch it. So if you move it forward, I use my thumb, move a little bit. They always give you a very good view. And you can move it back at the end of the surgery by putting your finger in the side of the ear canal. So whether you put it back or not, I don't think it matters at all, because you're not moving a lot. You're not closing off the ear canal at all. It's at most 2 millimeter.
Okay,
so
thank you.
Long-term result, I will let Bruce answer it. He has more information on the long-term.
Yeah, but we will come to the results from China as well. So Bruce, where are you? I don't see you on your picture, but comment on the long-term outcome.
Wilco, can you put on my slide number 6? Can you get my
Bruce,
slides up?
Bruce, I cannot. I'm sorry.
Okay.
But Bruce, you can describe what's on this slide.
All right. I will tell you that we have followed the pure tone average at 125, 250, and 500 for up to 15 years on several patients. The long-term that we have are 24 patients with 83% at 15 years still using their acoustic component. This was a 10 millimeter electrode, and it is about 60 dB to 70 dB long term. The best that we've done is 91% preservation in the Slim J. Again, it was it's a 20 millimeter electrode, and we would put it in 17, 18, or 19 or 20 millimeters depending upon the ECOG. We have 91% of 23 patients at 2 years. That's a shorter term. We have another group that's about 80% preservation at 5 years. So the bottom line is that if you preserve hearing beyond 6 months, the majority of these electrodes allow the cochlea to continue to have acoustic hearing in those low frequencies. And it's really important to keep the low frequencies above 80 dB, because that's audibility. If you go below 80 dB, that is not that acoustic component is not audible with even the strongest acoustic driver. So it's got to be in the range of 60 to 70 dB of pure tone average of those 3 frequencies.
Okay. Do these patients that you mentioned use a hearing aid, or they refused to use the hearing aid in addition to electric?
Yeah. If they have really good hearing at 20 to 30 dB in the lows, which I've got a group of patients that have a 10 millimeter or 12 millimeter electrode that have really good hearing, those people, some of them don't use a hearing aid, but most of these people are still using an acoustic and electric component together. And we can get into how you have to really demand that these people use that, because they don't like it when it starts. It's sort of like single-sided deafness. People do not like the combined acoustic plus electric for the most part, but they get used to it.
Well, to give some more information on the question, if I remember the literature correctly, for example, Gstöttner has shown that about 2/3 to 70% of the patient continue to use the hearing aid in combination with electric stimulation. And also from the literature, we see that there is a decrease of about 10 decibels per year in hearing loss in some patients. So that's also which might be considered when aiming for electric acoustic stimulation. What's the feeling on the panel on that?
Well, Joachim, we have some data that shows that long term, if you follow people with good low frequencies and poor high frequencies, they lose about 1 dB per year in their lows. They lose it a lot faster in the highs than they do in the lows.
I am very impressed about Bruce's results on long-term preservation, because the presence of the electrode inside the cochlea must lead to some inflammatory reaction and fibrosis that will change the hydrodynamic balance of the inner ear. So it's very interesting, this long-term preservation.
So there's only, can I address that a minute, Joachim?
Yes.
There's only
Please.
one patient that we had that lost his hearing at about 3-4 months. And it's interesting, these patients don't even understand that they've lost their acoustic component, because they have been using the electric and in a bimodal phase. But he came in, lost his hearing at 3 months. He then 7 years later died of cancer of the bladder. And we have his temporal bones, and they were processed at Mass Eye and Ear by Joe Nadel and their group. And in that patient, what we found was there was extensive fibrosis in the basal turn. But if you look at the hair cells that were in that cochlea, they looked in the ear that was implanted versus the contralateral ear that wasn't implanted. There was no difference in ganglion cells or hair cell counts. So it was, we felt that there was fibrosis, just like Oswaldo said, in this particular patient. Unfortunately, we don't have any more patients that we have temporal bones from,
fortunately,
to give us any more insight.
May I ask a question to Bruce?
Yes.
Excuse me, Bruce. Who is the youngest patient that you implanted with for hearing preservation? The youngest.
The youngest is about 9 years old. We wait, we don't do the very, very young patients, because we don't know what their acoustic hearing is really like at this stage. You're always trying to do soft surgery, but the point is that teenagers, when they lose the ability to understand on the telephone, want something else. And so we only have about 10 patients that are under the age of 18 that have acoustic plus electric hearing.
Yes, I agree with you. Also, in my experience, I have also adolescent, not very young patients, about 10, 12 years.
Yeah.
Okay. But Antonio, you have experience with children or adolescent with hearing preservation surgery as well?
Yes, just as I told before, I have experience only in few children, but the age are from 10, 12. And the results is quite well. I have to discuss about the point. I have all the other panelists. What do you think to use this technique in case of asymmetric hearing loss or in case of single-side deafness? Do you think it could be useful this kind of electrode in single-side deafness?
Who wants to answer first?
Well, I will tell you that the length of the electrode probably impacts the perception, and when you get closer to matching the place pitch, it's easier earlier for the patient. So if you have no residual hearing in an ear, I would probably use a 24 millimeter electrode and try to do soft surgery as much as possible. But if you use a pre-curved electrode, it's very difficult to even preserve structure sometimes in those patients. But I would try to match the pitch as much as I could. If I had residual hearing, I'd try to make certain I could preserve that hearing and not go in as far. You know, that some of our original hearing preservation of 15 years is with a 10 millimeter electrode. And those patients are at 70 to 80% correct on single words. And they do better in noise. So there's a real advantage to try and keep the acoustic component if you've got it to start with.
Well, I think to answer this question, which brings us a little bit away from hearing preservation, but as Bruce said, the tonotopic match would lead in single-sided deafness in children, and we do children with single-sided deafness from 2 years on and older. We would clearly choose a long electrode, and that would mean a 31 millimeter flex soft electrode, just to have better tonotopic stimulation, and also having van der Heining's work in mind that we need apical electrodes for perception of low tones. So in children with no residual hearing, this would be our choice. But let's come a little bit back to hearing preservation, and it seems clear that shorter and longer electrodes may make a difference, and I would have loved to hear Thomas Lenartz's opinion on his data on that. And
Thomas is coming. Give me another two more minutes. Yeah.
Okay, I will do that, and we'll bridge the time. And I would like to comment maybe you know the paper of Vanna, for example, to discuss a little bit of predictive factors for short and long time of hearing preservation, and share your experience on that. And then we will put the compressed questions and the pressure on Thomas. Bruce, what are predictive factors for outcomes? What gives better results than others?
All right. So I will tell you that if you have more residual low frequency hearing, the results are better. The reason to try and preserve hearing is to try and improve hearing and noise. And that's really the gold standard. If you look at standard cochlear implants and listening in noise, even the best results at a signal to noise ratio of 10 dB is about 40% correct in AZ bio sentences. In our patients that you preserve good low frequencies, you can have up to 80 to 90% correct at a signal to noise ratio of 5 dB. The better the low frequencies at 125, 250, and 500, the better you can preserve it, because you're going to drop down 10 to 15 dB in your acoustic by putting any electrode in the cochlea, whether it's long or short. But the bottom line here is that we want to try and give people better hearing and noise. So it would be better if we have 90 to 95% preservation of hearing, we could implant people with 30 to 40 dB hearing in the lows and give them better word understanding and noise, because hearing aids don't do it. And either do standard cochlear implants. Electric only hearing does not improve signal to noise. And that's the bottom line. I mean, we've been doing this for 20 years, and we've got central adaptation going on that demonstrates that you have to have that fine structure of the low frequencies to separate the fundamental frequency of the voice from surrounding noise.
Yeah, but we have patients with long electrodes who have pretty nice signal-to-noise ratios with -5 dB. But your short message is choose the patient with the most residual hearing to get a good outcome and a good hearing preservation rate, right?
I agree, yes.
More or less. But what can do Chinese hands to improve the outcome and the hearing preservation? Michael, what's your opinion on that? What are predictive factors?
I'm glad that Antonio put up the question of children over here, because I know most of us are doing things differently when we are implanting children and adults, because in children we are not absolutely using the audiologic criteria the same as in adults. So we're implanting children with more residual hearing than those adults. And this also transcribes into the fact that we're trying to do a electroacoustic study many years ago. Remember that we're part of the multi-center study. But over a period of 3 years, we just cannot find anybody. We just can find only one adult who fits into the electroacoustic criteria, still have significant speech perception problems with good residual low tone hearing. So our patients in Chinese with good residual hearing, they do have very good speech perception score, so they don't need a cochlear implant by definition, by the current criteria. So we don't implant most of them. Okay. Yes.
I have a question related to that. Chinese is a tonal language. Does this maybe make a difference? And how does this have an impact on your patient selection? For us, the comparison is Chinese language is for Western languages more to music appreciation. Do you see differences with residual hearing preservation?
Yes and no. The good performers are really also good musicians and music appreciators. But for an average performer, you need very little acoustic information, because the Chinese language is also a language for pattern recognition. So, for instance, when we are talking on everyday sentences, people will recognize the sentence by the pattern of the entire sentence. So they don't really listen or be able to differentiate word by word, okay, by the whole sentence pattern. So some of these people will be doing fine at home, but they are not doing well outside when they're talking to people with completely different sort of sounds or patterns of speech. So when you talk about the higher end of speech perception, yes, they do need to be very skillful. But when you talk about in general, the everyday sentences, they don't really need to know a lot. They just need to recognize the entire pattern of the sentence. So that's why it depends on what you're using. So if you use word score, it's very difficult for most of my patients. Sentence is very easy for them.
Okay. Antonio, you mentioned children. Is it for children easier to leave surgery with preserved hearing compared to adults because the ear is younger or the pathology is different? What's your feeling on predictive factors for hearing preservation in children?
I think the situation is different between children and adults. In children, there is a high probability that you have a worse hearing after surgery than in adult. I think that the predictive factor could be the etiology of the hearing loss. In case of congenital hearing loss, I think it's possible that you have more possibility to have hearing preservation and you have a good result as a follow-up than in patients that have a cytomegalovirus or other pathology that is the cause of the hearing loss. And especially my selection for the patients is that the patients that I will perform the kind of surgery, use this kind of electrode, is a patient without any other associated pathology. Because in children, this is one very important problem. sometimes, often, the hearing loss is associated with other pathology. In this case, the results, the follow-up after a long time, it's not very good.
Oswaldo, what are your impressions on which factors you can influence as a surgeon the outcome, or what is important in patient selection for you?
Well, besides the technique that we are discussing about, the software insertion, etc., I think Antonio put a very important point. I think the etiology of the hearing loss play a role very important in the long-term hearing preservation, because if you have a genetic hearing loss, I think the prediction is a little bit solid, but if you have infections or autoimmune or immunomediated lesions, etc., even in adults, if they have diabetes or hypertension or any kind of immune disturbances, I think if you do a very good technique, you have to deal with the other factor that can jeopardize your electrode stability in the ear. So I think the etiology and the presence of comorbidities are very important in long-term results, besides the technique, of course.
Let me ask, yes? Bruce?
I was going to say there are a couple of other issues that are predictive also in adults, not maybe in children. Age of the patient. We know that people in their 80s have more difficulty merging the acoustic and the electric components. And we know that people that have had long history of noise exposure probably don't do as well because there are dead areas in the cochlea. And so you wouldn't want to use a very short electrode with someone with noise exposure. So those are some things that you have to keep in mind. We usually don't do hearing preservation in people over the age of 75, just because it's very difficult for them to combine the acoustic and electric.
Yeah. Well, thank you for this comment. I think this leads us to an important point, that preoperative patient selection remains critical, and the difficulty will be how to decide to go for a classic cochlear implant or for a hearing preservation and combined electric acoustic stimulation. I remember the slides you have sent beforehand, Bruce, and mentioned something about 2 and 3 kilohertz ratio and hearing loss on that. Can you comment on that a little bit? And then I will.
Yeah. As I was saying, that the length of the electrode really does have an impact on your long term. I mean, we're getting better with ECOG. I think ECOG monitoring is extremely helpful in trying to see what's going on in the cochlea. You can't feel it. I mean, I can't. I can't tell you if I'm doing damage or not doing damage. But I will say that when we have someone that has better than 80 dB at 1500 hertz, we think they have pretty good neural survival in the base. And so that has been an indicator to use a little bit shorter electrode for us, as I'm trying to balance this risk-benefit ratio between length of electrode and preservation of low-frequency hearing. And so if you have 80 dB at 1500, that's a pretty good cochlea. And that's what I would use as telling me that I would be okay and that they can accommodate to the place pitch mismatch more easily than someone that might have profound hearing loss for 20 years in the highs. Those people you can't use a short electrode on because they probably have dead areas in their cochlea. from that long-term loss.
Yeah, thank you for that. But I want to expose you and the panel with the, well, Germany generally accepted 50-500 rule, which came from Thomas Lenarz, who is now joining the panel. I see a picture of him down there, but he will have a couple of questions on that. But let me quickly ask the others on preoperative rules like Bruce described with 2 and 3 kilohertz or the German 50-500 rules. Do you have similar things?
Das müsst ihr jetzt sehen, das müssen wir noch sehen, dass wir hier diese Verbindung herstellen zu dem Projekteur.
Yeah. Michael, can you comment on acoustic or audiologic criteria prior to surgery? And we're all watching Thomas Lenarz to get his setup done.
Yes, we for electroacoustic we don't really set up criteria, but for cochlear implant, yes. So which is we use the FDI as the speech perception score. So the word size has to be 50% or lower. So we haven't changed much. But we also put up more recently the asymmetrical hearing loss group with the 50 rule, very similar to the German rule. So we also find that quite useful for us as a guide as well. Yeah.
Antonio, what's the Italian standard?
Joachim, can we bring some questions in from some? We've got Arno Dietz online now, and he has a question about the orientation of the insertion. Perhaps Arno, would you like to unmute and just ask your own question?
We cannot hear you.
Yeah, thank you very much, Chris. Thanks, Bruce, for the nice video you showed. I have some question on the insertion trajectory. We saw on your video it was a right ear, which you were inserting with your right hand, and you came with an angle which was quite perpendicular to the round window membrane. Do you think that there is any difference if you're going more tangentially, like if you're inserting with your right hand a left ear, than if you come from more inferiorly right ear with your right hand, or should you just learn to be both-handed?
I will tell you, I can use both hands, but even in a left ear, I would use my right hand to try. And my orientation is always as parallel to the posterior canal wall as I can get. Because if you look at a CT scan in the axial plane, you will see that the cochlea is almost parallel to that posterior canal wall in its orientation. And so being more vertical and coming down on that, on the cochlea, it seems to help. And, you know, I do it very slowly. And so I'm trying to adjust it as I go to make certain that I'm as perpendicular as I can get. I guess that's all I can tell you is what I found to be helpful to me.
Well, thank you, Arno, for this question. Thank you for your excellent observations and putting this question of trajectory into the panel. More questions, Arno?
Not for the time being, but I think we should all be aware of the fact that we are doing a surgery, let's say, for 1 hour, 1.5 hours, sometimes more. But then we have the crucial, 2 to 5 minutes for the insertion, and this is the point where we win or we lose. Right. And this is therefore we have to, or what we are looking at is to get the trajectory right, and this is something which is quite difficult to do on 2D imaging. If you have virtual reality and with the glasses on, and you can see really the cochlea in his three-dimensional form, then you can somehow appreciate before the surgery how this will go in the end. With 2D imaging,
the word is augmented reality. The word is augmented reality, not virtual reality.
Actually, we are not yet there for augmented reality. That would be nice to have the navigation and the 3D picture in your microscope, for example. But what we try to do is to see whether we can get a little bit better when we do a virtual reality preoperative planning.
Okay.
And this is something we really should look into.
Oh, Arno, I can invite you to Munich, and then we visit the Ariscope, and then we can work on augmented reality together. That would be fun.
Joachim, invite me to them, please.
Yes, please, please. Our pleasure.
Well, I'll be there as soon as I can travel. Thanks.
Yeah. You mentioned, Arno, the insertion speed. Bruce has said he takes 10 minutes, 20 minutes, and I really admire his patience while doing that. Let me quickly ask the others, Oswaldo, Michael, and Antonio, how long time do they give themselves or the audiologist for the insertion? And hopefully then will Thomas Lenarz ready for a couple of condensed questions and pressure on him. Let's start with Oswaldo, please. How long?
Okay. I must confess that I don't have a Bruce patience. I don't take 10 minutes, but I try to put it more slowly than I can, and trying to feel any resistance to slow down. If I sense some resistance in the progression of the FA electrode. But I think one thing I do a little bit different from Bruce, I put the electrode a little bit more vertical, superior to inferior. I think it feels better for the first turn of the cochlea, the basal turn of the cochlea. I think the resistance is low, and for me, I put it slowly, but maybe 1 minute, 2 minutes at maximum, and I think we don't have the ECOG intraoperatively still. Until now, we don't have it here in Brazil. So I try to feel the progression slowly and without resistance. I think it's my most feeling.
Antonio.
I agree with you. I prefer the system that about the insertion at maximum 3 minutes, but maximum 3 minutes, not long time. Maybe it could be better to be slowly, but it's the time is.
Michael? How long do you take?
I have a slightly different experience. I don't believe in time because many years ago I was part of a study. So we went all the way to California. Actually, there was a table who measure how much movement we are, and then subsequently we also performed some temporal bone study into insertion and insertion trauma on another occasion in Paris. So I know that if I use my right hand steadily, I don't exert a lot of insertion trauma if I do slowly. So I still keep the same technique, but I can't use my left hand. So I've tried many times with my left hand. So I echo with Bruce that I will always use my right hand, even on both ears. So different surgeons will have different sort of like insertion trauma according to this, because we study different surgeons and know that they have different. And also I know it also depends on the stamina that you have. For those who play FIFA video games, you know what is what I mean. So if you have very good stamina on that day, you can hold very steadily without much trauma. So I just don't understand how we can insert with our free hand in 20 minutes slowly and steadily without any mechanical assistance. So I'm still figuring it out myself. We do have robots in research, but I'm not sure whether this is going to be the future. Yeah.
Okay.
But know yourself.
Can we see, or Professor Lenarz, can you hear us, or we see you nicely on the screen, but I'm not sure if you're completely connected.
Ja, aber er spricht ständig zusammen.
Can you hear, Thomas?
Steht auch am Bildschirm, ne? Das ist alles nix, ja.
Yeah.
Okay.
Antonio, please, yes?
Yes, because Thomas can't understand, can't hear. Oh, I have to add
I apologize for German technology in northern Germany.
And I think it's very important the vector of insertion, and so I perform cochleostomy with the left hand on the left side. I insert the implant with the left hand. I think that way I can have a better vector for insertion of the array. Of course, it's a choice of the surgeon.
That was actually my comment on the trajectory, because I think we have to go very tangential to the round window, and to keep the friction down as much as possible. We know that we have some electrodes like the metal electrodes or the Oticon Ever, which can be quite floppy at the basal part, and I think in this way you can achieve, now I'm speaking of deaf ears, very deaf ears, also a full insertion. With those shorter ones up to 20 millimeters, I think it doesn't make so much difference. But still, I think this is also one point which perhaps should be taken into account when you really want to preserve hearing.
Any comments on that?
I agree.
Well, you agree? Okay.
Joachim, can I come in again with some questions from the audience? We have one question about asking the panel what they think about the modified Veria technique named as the Bhopal technique for cochlear implantation. Do you have any comments on that, on the Bhopal technique?
Oh, let's start with Antonio. Do you know this technique?
Really no. Which technique?
Well, I don't know the technique.
It's from Sharmela Sondi. What we might try and do is see if we can bring Sharmela in to describe the technique and ask what your thoughts are. If you give me just a minute, I'll see if I can get Sharmela in. Let's just see. Bear with me a second.
Good, but at least 3 people of the panel do not know which technique is meant.
Okay, what we're talking about. Well, I certainly don't, but I'm not an implant surgeon, so.
Michael doesn't also know, so nobody knows.
Nobody knows anything about it. Okay, well, we'll maybe wait for a little bit, see if we get Sharmela in.
It's a special
very educational. But maybe we can discuss whether we should vary our technique and if this might give advantages. Varia technique is Varia technique was described 20 years ago by Trifon Keratzidis and used a little bit like an enlarged androtomy and guided the electrode around through the incus and the antrum into the tympanic cavity, lifted up the tympanic membrane, and then inserted the electrode So attachment of the incus could not avoid it to my extent, but what's your feeling on these comments?
Sometimes
so
I use
I'll comment. Is what you're describing is elevation of the posterior canal wall skin. Is that correct? And putting a groove
barrier means in principle androtomy, lifting up the tympanic membrane like in stapes surgery, and then insert the electrode after guidance through the antrum from anteriorly.
This is also a Cronenberg technique.
Yeah, I guess this is a kind of suprameatal approach.
Well, it was the forefather of the suprameatal approach, so to say.
Yeah.
And maybe Bruce does not know this is a pure European development, but let's start with the comments a little bit in organized order, and we start with Antonio, and then Oswaldo, Michael, and then Bruce. Antonio, you know the South European Varia technique.
Yes, I know this approach, the approach. I don't use it, but sometimes I use a combined approach. In some cases, you have some information of middle ear, especially very young children, so I perform cochleostomy through the external middle canal. So in this case, but I perform at the same time also the posterior timpanotomy. So I insert the array through the posterior timpanotomy, and I perform cochleostomy from the supranatal approach. In this case, we have a better view, but very, very few cases. I use that about in 10 cases. Malformation.
Okay, Oswaldo, you know Varia technique or have similar experience?
Yeah. Yeah, we don't use it regularly, just in rare cases. If there is a small space for posterior tympanotomy, far anterior fascial nerve, or non-developed mastoid, it's very rare. I think it's much more easier to insert traumatically the electrode by posterior tympanotomy than trans canal, because you have a perpendicular angle for the round window, so it's more difficult to the pressure that you do. I think it's different, so we don't use it except in exceptional cases with a very difficult performance by posterior tympanotomy.
As you mentioned, the lifting up the tympanic membrane is helpful in malformations. How is the Chinese experience on that?
Yes, I actually rediscovered this technique about 4 or 5 years ago, when we are looking at using the endoscopes. So I don't use it in every case, of course, but I will use it in 3 situations. 1, very bad otosclerosis patient, which we will need to look carefully. 2, as you said, malformations especially allow us to see the facial nerve and its relationship with the cochlea much earlier on and easier. So we start with looking at it with the endoscope. And 3, very bad cases of the outer ear and middle ear after radiation. So we have a lot of radiation cases like this. Okay, so and we also use endoscopic assistance as well, and total endoscopic techniques, but not now. So we use endoscopic assisted techniques now.
Bruce, you have learned about old-fashioned European techniques. Is it something that raises your interest, or you want to comment on that?
So, if I'm understanding correctly, in Israel there was a gentleman that was lifting up the posterior canal wall and then putting the electrode in, drilling a channel. Very early on in the United States, that process resulted in breakdown of the posterior canal wall skin, and then exposure of the electrodes, and so we have really stayed away from that in the United States. If we have a situation where there's, like Michael was talking about, radiation, we would probably do a subtotal petrosectomy and take down the canal wall and get rid of the middle ear and tympanic membrane, and insert the electrode in those very severe cases. It's pretty rare that we have to use anything besides the facial recess in our experience.
Well, if we start with subtotal petrosectomy, we can continue to discuss for a couple of more hours, but I see time is running.
Yeah, I think Joachim, on the chat, just to tell people on the chat, Sharmila Sondi, who asked the question, has posted the YouTube film of 4 minutes. If anybody wants to catch up on that technique, we've got 2.5 minutes left. So I think Joachim, if you and Bruce want to wind up, that would be great.
Yeah, I wonder whether Wilco could insert the slides that I have sent beforehand.
Dr. Muller, I'm back, yeah.
Hello. So,
sorry for technical insufficiency. Everything had been said. It's all great. Thank you.
No. Wait, Professor Lenarz. We have some questions remain for you, and we want to hear some of your experience on the data. And we have discussed pros and cons of hearing preservation, and we have heard about hearing preservation. But I remember your slides on different categories of hearing preservation: partial, complete, or moderate, and also on the results related to different electrode lengths. And that was a controversial point a little bit in the discussion. And I would like to ask you to share your data on that, how electrode length has an impact on hearing preservation. Is hearing preservation always the same? Or do we need a classification of hearing preservation grades? And please give your comments and experience on that.
And Thomas, you have 46 seconds, so that'll be a challenge.
Yeah, only 40 left. So the longer the electrodes, the higher the risk for hearing loss. If you stay below 20 millimeters, then you have a fair chance for hearing preservation. Everything beyond 20 is risky. Hearing preservation makes sense if the predicted post-op threshold at 500 Hertz is better than 65 dB. If it's worse than that, don't try for that, but go for full coverage of the cochlea, so providing enough space for electrical stimulation only. So that's it.
No, Thomas, you have more time. No, Thomas.
40 seconds.
No, that's too fast. Too fast. Please, Thomas.
But one more question to Thomas Lenarz. You said that shorter electrodes are better, but is it? But I remember your data that you also with longer electrodes preserved some degrees of hearing. Wouldn't that be a goal for the future to combine both worlds, to have a little bit longer and hearing preservation?
That's the concept. The concept of partial incision, so that we implant long electrodes only partially, and so you have better chance for hearing preservation. And the implantation depth is dependent on the residual hearing and the length of the cochlea. So once you have then a loss in the future, then you can basically insert the electrode deeper in, and then you would go from, let's say, electric acoustic stimulation to electric stimulation. So that's the concept we now follow, and we individualize it depending on the length of the cochlea and the amount of hearing loss or the residual hearing. And we also go for intra-op echo to monitor the preservation.
Okay, I have two questions. One is to Wilco. Can you insert the slides that I have sent? Oh, yes. But before we go through the conclusive slides, I have a question to the panelists. Can anybody imagine a case where it's not worthwhile, independent of the residual hearing, to apply a hearing preservation surgical technique while setting a cochlear implant? No. Okay, then we go through the next slide.
Okay. Joachim, 2 minutes.
Yes.
Structure preservation, no?
Yeah. Well, as Thomas Lenarz said, structure preservation is a key. And from the slides that Bruce has sent in, we conclude, as it worked out with the panel, that hearing preservation, it's always worth to consider, and that should be a standard today. As you have seen on the insertion depths with one of the questions of the audience, the individual cochlear duct lengths should be reflected. Also, Thomas Lenarz concept of reinsertion or later insertion of a Langer electrode pays attention to this. And even if Bruce feels that round window and cochleostomy are equally good, the literature says that there are advantages for round window access if we aim for hearing preservation. Next. So preoperative patient selection, as we have discussed, is critical, and I want to draw attention to three groups that Bruce has nicely worked on. For those patients with substantial functional hearing, where we may go for shorter electrodes, or with some functional hearing where lateral wall electrodes should be the one of the choice. And we have a third group with patients of non-functional hearing that showed for full lateral wall electrodes. And as Antonio pointed out, individualized cochlear implantation using measurement system prior to surgery may give additional advantages to the patients. And I think these are the conclusions. I would like to thank Wilco and Robert for setting it up, and now I'm finished.
Okay, thank you. I want to thank you very much for a very interesting meeting.
Thanks, everyone.